recent issue of the Journal of Indian Academy of Cardiography, where the article is published, Role of Cardiography in Guiding Transcatheter, Aortic and Mitral Valve Replacement, Dr. Bansal and Casliwal. It's a nice article you can go through. There are videos associated with that and the pictures, which gives you a lot of information. There are 4 types of transcatheter mitral valve replacement which are being done. That is, the first one is, the most common one is transcatheter mitral valve replacement inside a degenerated bioprosthetic mitral valve. This is one of the commonest one which is being done. Then the next one is the failed previous mitral annuloplasty ring repair. Third one is extensive mitral annular calcification, where it is really difficult, and also in patients with native mitral valve regurgitation. The main methodology is transeptal puncture and reaching the mitral valve and replacing the mitral valve. That is the one which is being practiced. Previously, they have tried transapical, transatrial, and also transfemoral. So these are the other methods which can be done. The structural degeneration of the bioprosthetic valve is quite common. Say, usually, previously, the valve lasted for only 7 years or 8 years. Now, with the advent of the newer technology in preserving the valve lasts for about 10 to 15 years. But it depends upon the age of the patient, the site of implantation, the type of bioprosthetic valve, and other risk factors like patient process mismatch, smoking, diabetes, end-stage renal disease, hyperparathyroidism, etc. All of this affect the functioning of the bioprosthetic valve. So the structural degeneration is quite common. Pre-procedural assessment is mainly done by echocardiography, transthoracic, transesophageal, and 3-dimensional echocardiography, which we are doing regularly. And cardiac CT is also useful in certain instances. The main echocardiography use is to assess the valve itself, whether the bioprosthetic valve is functioning normally or stenosed or regurgitant, and also to determine the mechanism of the mitral valve regurgitation, to recognize potential contraindications for anticipated complications with transcatheter mitral valve replacement. And also, one other thing is, because we are going transseptal, interatrial septal anatomy, and the site of puncture should be assessed by echocardiography. This is the mitral valve assessment by transthoracic echocardiography. We have to look at the mitral valve cusp, whether they are opening and closing normally. You can assess the colored Doppler jet and also get the gradient across the transmitral valve. And you can calculate the peak and the mean gradients, and also calculate the effective orifice area. This is a patient with a degenerated bioprosthetic valve. You can see calcification of the bioprosthetic cuffs, and the patient is atrial fibrillation, markedly dilated left atrium, and the gradients are markedly increased. In this patient, it was about 16 and 10. So this patient has got a degenerated bioprosthetic mitral valve, which may require replacement, either by surgery or by transcatheter replacement. And the 3-dimensional echocardiogram also helps in the assessment of the 3 cusps of the bioprosthetic valve. This is another patient with again, this clip is not running. So this is a patient with severe mitral regurgitation. So this patient has got stenosis, mild stenosis, and also severe mitral regurgitation. This patient has got a TR jet velocity of 3.9 with a severe left ventricular dysfunction. Other complications may be associated with the bioprosthetic valve. This is a patient with atrial fibrillation who has got a left atrial thrombus. This is another patient with vegetation over the tricuspid bioprosthetic valve. And the gradients are usual gradients which are applied for the native mitral valve stenosis can be applied for the bioprosthetic valves also. The mean gradient of less than 5 is normal. 6 to 10 will be possible obstruction, and more than 10 will be significant obstruction. So we go by the mean gradient across the bioprosthetic valve, and also by the effective orifice area, which is calculated by using the transmitral gradient and the LVOT Doppler. This is another patient with calcification of the mitral annulus. There is a dense calcification of the anterior and the posterior mitral annulus, And you can see the gradient across the mitral annulus is 26 and 15, indicating a severe mitral obstruction. This is the three-dimensional echocardiogram, which shows clearly that all the 360 degrees, the mitral annulus is calcified. This is another patient with anterior and the posterior mitral annulus calcification with significant stenosis and also significant mitral regurgitation. So for assessing the mitral valve in patients with mitral annulus calcification, the CT scores, you can see whether it is the calcification is extending for 90 degrees or 160 degrees, all the 360 degrees. This can be assessed to a certain extent by echocardiography, but better by using the computer tomography. And the sizing of the valve, etc., is completely done by the CT use only. In the pre-procedural assessment, multi-detector computer tomography is useful for assessing the vascular access route to select appropriate valve size and also in predicting the neo-LVOT size and the risk of LVOT obstruction. So there is a computer modeling which is going into this one to assess the neo-LVOT size, and from that we can predict whether the patient will develop LVOT obstruction. This is the sizing of the valve by using the CT. We can get the side-to-side diameter and the anteroposterior diameter. Both diameters can be measured, and we can assess the diameter, the size of the valve which is required for replacing the mitral valve. And this is the computer modeling which tells you the size of the neo-LVOT. And if they say that if you are going to implant the valve deeper into the left ventricle, then it may produce LVOT obstruction. Then if there is a flaring of the anterior portion of the prosthetic valve, then again it can produce narrowing. And then the angle between the mitral and the aortic annulus, again, if you tilt it towards the LVOT, then it can produce LVOT obstruction. Lastly, if there is a septal hypertrophy, this can narrow the left ventricular outflow tract and it can produce obstruction. The left ventricular outflow obstruction is defined as an increase in the gradient of about 10 millimeters of mercury from the baseline is taken as LVOT obstruction. This is very less in patients in whom we are going to replace the valve for their failed bioprosthetic valve. It is about 0.7 to 2.2. For the native mitral valve, it is about 5%, and in valve in mitral annular calcification, it is almost 10 to 40%. If the neo-LVOT area is measured by computer modeling, if it is more than 200 square millimeters, the chance of LVOT obstruction is very less. Whereas if it is below 170 square millimeters, the chances are 96% it will produce, there will be some LVOT gradient after mitral valve replacement. For these patients, they do what is called a lampoon procedure, that is intentional laceration of the anterior mitral leaflet to prevent left ventricular outflow obstruction. Then lampoon is the short name, where they by a catheter which pierces through the anterior mitral leaflet, and it is snared by another wire which is passed through the aorta, and then they cut through the anterior mitral leaflet and split the anterior mitral leaflet into two. So by this, the anterior mitral leaflet is split into two. When they are putting the valve separates out rather than being drawn into the left ventricular outflow tract. You can see the thing, this is without lampoon and this is with lampoon. So the lampoon procedure avoids the occurrence of left ventricular outflow obstruction in patients in whom they are prone for LVOT obstruction. This is another patient which we saw say this is actually the valve itself is positioned as if the flow is occurring towards the left ventricular outflow tract. If you have a valve like this and you put if this valve fails and you put a transcatheter mitral valve replacement, you are going to have a left ventricular outflow obstruction. And periprocedural echocardiography and fluoroscopy are the main methods of used for assessment. As soon as the procedure starts, you have to confirm the catheter the previous findings and confirm that the valve is degenerated, stenosed, and all that. This is a patient with whom Dr. Gopal Murugan has done a transcatheter mitral valve replacement. You can see clearly there is a flail cusp for the bioprosthetic valve, and the main in the say main thing for which echocardiography is useful to is to puncture select the puncture sites. So for this, two views are used: the bicaval and the short axis aortic valve, a 90 degrees aortic valve. Here we can say exactly whether the catheter is puncturing catheter is inferior or superior, and in the short axis view you can say whether it is posterior or anterior. Usually for transcatheter mitral valve replacement, you go from a superior and anterior portion of the interatrial septum. As soon as you select this site, then go to the apical four-chamber view and measure the height of the distance between the puncture site and the closed mitral valve. It should be at least 3.5 centimeters to 4 centimeters for you to perform a successful transcatheter mitral valve replacements. So those two views for assessing the height and all that, echocardiography is very useful, transesophageal echocardiography. This shows the puncturing of the interatrial septum, and after puncturing, there is a dilatation of the interatrial septum by the balloon for the device to be put into the left atrium. And say sometimes when there is a calcified valve, it may be difficult to cross the mitral valve orifice, and actually a three-dimensional echocardiography can show the exact place where the mitral orifice is situated, and it can guide you to cross the mitral valve orifice. After crossing, you can see this is how they are crossing the septum and crossing the mitral valve. And then the actual balloon valve is implanted by dilating the balloon. Here you can see the valve is getting positioned, and we can assess how much of the valve is above the ring and below the ring. You can do it by simultaneously looking at the echocardiogram and also the fluoro. Then the balloon dilatation is done. You have to do a rapid ventricular pacing and then dilate the balloon. And this is the final result. You can see the mitral valve which has been reimplanted, and nice valve cusps which are moving normally, and the three-dimensional echocardiogram you can see the cusps clearly. So the echocardiography, especially transesophageal echocardiogram, and also by using the fluoro, we can guide the transcatheter mitral valve replacement. This is another patient which I will skip. This is another patient done by Dr. Gopala Murugan again. So this was a patient with severe mitral annulus calcification. You can see the three-dimensional echocardiogram shows 360 degrees valve calcification. In this, you can see the catheter passing through the mitral valve orifice, and he's going to dilate the balloon to implant the valve. It is being done very, very slowly, because usually the calcium is very difficult to give. It will not give way that easily. And this is the final result. So this is the three-dimensional echocardiogram before implantation and three-dimensional echocardiogram after the transcatheter mitral valve replacement. Post-procedure assessment is mainly done by the echocardiogram. The echocardiography, especially immediately after implantation, it is very useful to assess the regurgitation, whether there is a paravalvular regurgitation or a valvular regurgitation. Especially if there is significant paravalvular regurgitation, the operator can go again and dilate it and try to reduce the paravalvular regurgitation. Other complications like LV perforation, pseudoaneurysm, mitral annular disruption, LCX occlusion, the say pulmonary vein perforation, etc., can be say diagnosed by echocardiogram, and these patients can be referred for open heart surgery. If their complication is severe, they have to be taken up for surgery. And access related complications also can be diagnosed. And say after the valve is implanted, we can assess the functioning of the valve by transthoracic and transesophageal echocardiogram. This is a patient in whom there is, after a transcatheter replacement, there is a significant paravalvular regurgitation. They have to go ahead and dilate it again to reduce the paravalvular regurgitation. If the paravalvular regurgitation cannot be reduced, then they can close it by a plug during the during the same procedure. So to conclude, transcatheter mitral valve repair and replacement procedures are complex. For adequate patient selection and technical success, procedural planning and guidance with multimode imaging is the key. So we have to use cardiography and also computer tomography for assessing the suitability. Transthoracic and transesophageal echocardiogram are essential for imaging tools to select the patients with favorable anatomy for transcatheter mitral valve replacement. For mitral valve-in-valve replacement, valve-in-ring, and valve-in-mitral annulus calcification procedures, cardiac CT is also essential in pre-procedural planning, mitral annular sizing, estimating the risk of LVOT obstruction, and also determining the landing zone of the tissue valve, and also to predict the incidence of paravalvular regurgitation. The precise sizing of the landing zone decreases the valve embolization or migration. Cardiac CT is the main tool for annular sizing, particularly in MAC, and also in assessing the neo-annular size. So, and echocardiography also is very useful during the procedure, along with the fluoro for replacing the valve, and complications can be assessed by using the transesophageal echocardiogram. And after the implantation, echocardiography is the main tool to assess the functioning of the valve and also finding out whether there is any significant valvular or paravalvular regurgitation. Thank you.